So we had basically looked at CPX-351 in the setting of a randomized trial against standard induction chemotherapy, 7+3, and found that the outcomes of patients who received CPX-351 were superior to patients who had received 7+3. And we also recognized that allogeneic transplant was part of the treatment continuum for patients with AML, even older patients. So we wanted to explore whether transplant was feasible in this group of patients and whether one type of therapy versus another prior to the transplant itself might affect outcomes following transplant. And in the analysis that we did, that we presented here and previously at ASH, we found that the patients who received CPX-351 did better after a transplant than patients who had received 7+3 as their initial therapy, leading to the consideration that perhaps CPX-351 might be a bridge, so to speak, to a transplant, and that more patients might be able to ultimately get to transplant, and the transplant could be more successful in the long run for those patients. We also found that age didn't seem to be a big factor in determining outcome amongst these patients, so that even patients between 70 and 75 who are considered the older group compared to patients who were 60 to 69, the older group, that there were not major differences between the two groups, and that both groups benefited fairly equally from having received CPX-351, both in terms of their primary outcome in overall survival, but also in outcome following allogeneic transplant.